Hello, welcome to the second virtual Lupus Mini Health Conference presented by the Lupus Foundation of Northern California. My name's Lori Day, and I'm excited to be your host today. I started as a volunteer at the Lupus Foundation of Northern California during the Outrun Lupus 5K in 2019, and then joined them part-time shortly thereafter. I've really enjoyed meeting and working with lupus patients, and I'm excited to be your host today. But this is my first time moderating, so bear with me. We are really happy you could join us today, and hopefully you'll be here tomorrow too. The Lupus Foundation of Northern California has one more upcoming Lupus Mini Health Conference planned for 2021, and that will be a Spanish language conference on October 16th. Don't miss your chance also to help out the LFNC Outrun Lupus on September 25th. Our 5K this year will be a hybrid event, so you could join us at the Campbell Park or wherever you feel comfortable. For additional information or resources, please visit our website, www.lfnc.org, or email us at communications@lfnc.org. Before we begin, I want to make sure you're all aware that this is a two-day event, and you do not need to sign up again for tomorrow's session. You can use the same link you used for today's. Last housekeeping item. We want to hear from you and hear your thoughts on this conference, so be sure to complete the survey when the webinar ends. This is the only way we can hear what you liked and any suggestions of what you would like to see in the future. So now I'm going to go over the agenda quickly, and we'll get started. The first hour, Dr. Balboni will discuss lupus in children, and she will follow that up with a live Q&A for about 15 to 20 minutes. You can ask questions by clicking on a Q&A button in your Zoom window and typing your questions. You can do this during the presentation or afterwards, it's up to you. And you can ask questions anonymously by clicking the checkbox next to your question before hitting submit. So don't be shy. No one has to know your name if you don't want them to. We will be moderating the questions. So if a lot of people ask the same question, don't worry about it. We'll moderate it and we will ask the questions to Dr. Balboni during the presentation or during the Q&A session. We will then reconvene. We'll take a quick break and then we'll reconvene at 1 p.m. for a wellness session. Today, we're excited to have two of our Living Well with Lupus practitioners joining us. We'll begin with some stretches and some meditation led by our lupus warrior and Kundalini instructor, Julie Viscuso. After that, we'll welcome Dr. Kat Lewis, who will discuss lifestyle and nutrition for autoimmune conditions, a holistic approach. We're really excited about today, so I hope you'll stay for both sessions. But now I'm pleased to begin our first keynote session. It looks like we have about 10 people in the audience right now, and we expect that we'll have even more watching after this is done. But let me introduce you to Dr. Balboni. Dr. Balboni is currently a clinical associate professor in the Division of Pediatric Allergy, Immunology and Rheumatology. She's also the program director for the Pediatric Rheumatology Fellowship at Stanford. Dr. Balboni serves as an attending physician in both the outpatient and inpatient setting at Stanford Children's Children's Health and Lucile Packard's Children's Hospital, Stanford, caring for pediatric rheumatology patients and mentoring trainees in pediatrics and pediatric rheumatology. She has been actively involved with programs supporting pediatric rheumatology patients, including the LFNC's annual Gala and Outrun Lupus. Today, she will be speaking about lupus in children. Welcome, Dr. Balboni.
Thank you. Thank you for that kind introduction. As Lori said, I'm Imelda Balboni, and I'm a pediatric rheumatologist here at Stanford, and I'm really excited to have this opportunity to talk to you today about pediatric lupus. Hopefully now you're able to see my slides, the title slide there. And one thing you'll learn is that we have lots of different names for the same thing. So sometimes you might hear me say childhood onset lupus. Some studies call it juvenile lupus. Some people say pediatric lupus, essentially the age that we're considering is generally patients who are diagnosed before or at age 18, although that can be quite variable. Some people would define it even as young as 16. So today, I am going to talk to you about quite a few things. First, I'll talk a little bit about the epidemiology of lupus. Who gets it? You know, what are the statistics? And then I do want to talk just briefly about our immune system, since obviously we're talking about a disease that affects the immune system, so it's important to have a bit of an understanding. And then I'll go into what we think is the cause, or what causes lupus, what's behind the pathogenesis of it. Talk a little bit about how we diagnose lupus, and then some clinical manifestations that are most common, especially in pediatric lupus. But what you'll notice is many of the things that I'm saying actually may apply, do apply to adult patients or all patients with lupus. But really, towards the end, we'll focus on, you know, why do we care about pediatric lupus? Why is it different? And what's the prognosis? What are the outcomes? And what are the things that we need to consider as pediatric rheumatologists and as parents of children with lupus that aren't necessarily as much of a challenge for adult patients? And we'll end with that, and then I'll be happy to answer any questions. Lupus, or systemic lupus erythematosus, you'll see it called lupus or SLE throughout the presentation, is a very heterogeneous autoimmune disease, meaning it can affect almost any organ system in the body, and every patient is different. I often say, you've seen one lupus patient, you've seen one lupus patient, because everybody is different. But it's really characterized, all of lupus is characterized by having a lot of inflammation in your blood vessels, your connective tissues, your organs, and a hallmark of the disease is the presence of very high levels of autoantibodies, and in particular anti-nuclear antibodies. And we'll talk a little bit more about that in a few minutes. What we know in adults in the United States, the prevalence is thought to be anywhere from 20 to 150 cases per 100,000 people. There's a strong female predominance, about 9 to 1. There are some studies that even say up to 13 to 15 to 1 in adults, but that does decrease in older population after menopause. It's much more prevalent in among people of color, so African American, Asian, Hispanic, Native Americans. There's just a much higher prevalence in all lupus patients of color. Interestingly, though, of all the lupus patients that are out there in the world, about 18% of them have onset during childhood or adolescence. And for those, so when we think about pediatric lupus specifically, it's currently thought to affect about 5 to 10,000 children in the U.S. And if you want to know, like, well, how many children get lupus in a given year, it's thought to be maybe half to one person per 100,000 children, or maybe 1 per million children in a year. So pretty rare, and more common in adults. When we look at the pediatric population, the median age of diagnosis is about 11 or 12 years of age. It is quite uncommon before the age of 5, although certainly we have seen patients younger than 5. There continues to be a female predominance, but prior to puberty, it's more around 3 to 4 girls to 1 male. After puberty, though, those numbers pick up more consistent with what we see in young women. However, one of the big concerning things we know about pediatric lupus is that our patients often present with much more acute and severe disease than than adults tend to. They have more severe organ system involvement, and we'll talk about that in a bit. And they tend to have more active disease over time, so often very challenging to get the disease under control and keep it under control. And lupus is, even though it's rare, it's the second most common disease that we take care of in our rheumatology clinics, second only to juvenile idiopathic arthritis. So next, I am going to give you a two-slide introduction to the immune system, which is not doing it justice, but just to sort of get us all on the same page. When we think about a normal immune response, say to a virus, this virus particle here is outside our body. It needs to get inside our body. It gets inside our body through our skin or mucous membranes, and that triggers a part of the immune system called the innate immune system. It's a primitive immune system. It doesn't have a lot of specificity. It recognizes a lot of just general things on viruses and bacteria. So it can react very quickly and start the inflammatory process. It does that within a few hours to less than a day. And as part of that, I apologize, I'm being texted for work, but I will ignore it. So if I look distracted, I apologize. It does that. It then subsequently helps turn on a more advanced part of our immune system called the adaptive immune system. And these are the cells that really drive autoimmune disease. But they are key players in fighting normal infections. So, for instance, this virus is now being recognized by our B cells, and they stimulate the B cells to become more mature and start making antibodies, and then we can attack the virus. Similarly, our T cells or T lymphocytes can recognize the virus particles and over time turn into these effector cells, or we call them killer cells. They are really good at destroying any cells that might be infected with a virus. So that's a normal process. And that's how we're able to survive in this world with millions of viruses and bacteria and all kinds of foreign things that might get into our body. The problem is with autoimmunity, something goes awry in here. And we actually know that many different steps can be affected in patients with lupus. So it's not just one thing going wrong that we could easily fix. There are different patients have different steps of this immune process that might be just a little dysregulated, have some genetic abnormality that's causing the immune system to overreact in some way. And we call that, or normally in the normal immune response, we have what's called immune tolerance. And that means that we don't recognize ourselves like a self protein or our self DNA. Instead, if that is going to, if we are reacting to something that is self, the immune system has special mechanisms, and I don't expect you to know what all of this means, but basically our immune system is smart enough to say, oh, wait, I shouldn't recognize myself. Let me shut that cell down. Don't let that T cell or B cell become mature and go and attack ourselves. And that's how we have tolerance to things that we should allow in our bodies, like our own cells. Unfortunately, with lupus and with, in general, most autoimmunity, one of the factors that's involved is somehow we lose the ability to maintain tolerance to ourselves. And so that leads us to, what causes lupus? And this is a very schematic, schematized figure taken from a review on lupus and pediatric lupus. And basically the idea is you start off with a person who has some genetic predisposition. And you're going to hear all about genes in the session tomorrow with Dr. Newald. And that's an area of great interest, and we're learning more and more every day about. But right now, I couldn't tell you if my patient has, a genetic mutation in X, Y, or Z gene, but we just know there are genes that can predispose you to autoimmunity. And then if you have that genetic predisposition and there's some environmental factors, whether it's an infection, something related to hormones, we know women are more affected than men, certain medications, toxins, something in your diet or nutrition, and in lupus in particular, we know UV light can trigger flares. So taking those two together, and something happens and we lose the tolerance to ourselves. When that happens, we start making, in this simplified version, antibodies. You might also have self-reactive T cells. So it's not just the B cells that can become self-reactive, but also your T cells. And so you have autoantibodies. That doesn't necessarily mean you have autoimmune disease, but over time, if those antibodies are binding to our self-tissues and causing an immune response to be more prominent, and you get inflammation, you start to have symptoms. And then at some point, you actually will have this, clinical features of lupus. And what we know, and I won't talk a lot about this, but we know the genetic predisposition is there, but it's not everything. There are studies that suggest even in identical twins, only 25 to maybe 40% of the time do both twins have lupus when one develops lupus. So it's not just the genes. So it's really complicated, and fortunately, Dr. Newald is really smart, and hopefully we'll be able to explain that better to you tomorrow. But the other thing that we do know is that in adults, at least, this process can take years. And there's some really lovely studies that were done in adult patients looking back after having been diagnosed with lupus and having samples of blood from them because they were in the armed forces to show that antibodies to certain cells proteins form 5 to 10 years before a patient meets the criteria for lupus. We don't think it's probably that long in our pediatric patients because obviously they're presenting at a younger age, and one of the hypotheses is maybe they have a stronger genetic predisposition or something that makes them present more quickly and more severely than some adult patients. Okay, so that's all I'm going to say about what causes the cause of lupus, and it's very simplified. Now, how do we diagnose lupus? There's no one test. People often go to their pediatrician, they have some vague symptoms, their doctor runs an ANA and it's positive, and they say, oh, you have lupus. That's absolutely not true. The ANA is something we see in lupus, but the diagnosis is really a clinical one based on symptoms. And to assist rheumatologists in sort of studying patients and classifying patients, rheumatologists have been coming up with classification criteria for lupus and every other rheumatologic disease. We love to make criteria and then test them and see how good they are. And so the first criteria that at least I was aware of are from 1982. So 40 years ago, these criteria were developed. And they were basically, a list of 11 findings, either physical exam findings or lab findings. And if you had 4 of those 11 things, you were very likely to have lupus. And that same criteria system stuck around until about 2012. There was a revision in 97, but it really for 40 or 30 years was there, 40 years. And then there were some criticisms about, some of the criteria, and some things didn't make sense, and there were other things that we thought should be in there. So a new group of rheumatologists got together and said, we developed these criteria, and they work better, and they're more sensitive, they're more specific for lupus. And then we have these new criteria, and we're like, okay, we're learning new criteria. Lo and behold, just 7 years later, there's a whole new classification system. So I'm still learning how to use this system in pediatrics. Of course, it was initially developed on adult patients, and so we always do have to verify that it will be as useful in adults. But it's very interesting because it's, for the first time, requires you to have an ANA to even consider classifying someone as lupus, whereas these other criteria, the ANA was a part of the criteria, but you didn't actually have to have a positive ANA to be diagnosed with lupus. And so this new criteria are a little bit, they're more stringent, and they also use a point system. So not every symptom or feature finding is equal. And so that is a very different approach to the compared to the old criteria. And this just shows you that you have to have a positive ANA. And if not, you don't get classified as lupus. But if you do, then we look at what symptoms you have, and you add up the points. And if you have a score of 10 or more, then you're considered, that you would be classified as lupus. And so this really does take into account some of the things that are much more specific for lupus, like if you have a kidney biopsy that's consistent with a specific type of lupus nephritis or kidney disease in lupus, you get 10 points. So that alone would give you a diagnosis of lupus. If you have other things that maybe aren't so specific, like you have anemia that's from hemolysis, and you have a fever, then you need a few more things to really make the criteria. So it's an interesting new criteria. We'll see where it takes us. Okay, so I do want to just talk briefly about the ANA, since I've mentioned it so many times. This test is basically, it's not one antibody. It is basically detecting any antibody in your blood that recognizes or binds to something in the nucleus of the cell. And in reality, it actually now reports things that bind to any part of the cell, so even outside the nucleus. So that's gotten even more confusing the more details we learn. But the thing about the ANA is it's very sensitive, meaning that if you have lupus, you are most likely to be positive for this test. However, it's not specific. People who don't have lupus can have this antibody, and even normal healthy patients, 30% of adults, maybe 15 to 20% of kids will have a positive ANA without any disease. They're just normal healthy kids hanging out there. Somebody runs an ANA and it's positive. It's also seen with infections and other diseases, other rheumatologic diseases. So it's really not a great test to order unless you really have a suspicion for lupus or one of the other diseases that it's associated with. And what it is it's binding to different things. These are different pictures of what the ANA staining would look like, depending on if it binds something that's more on the outside of the nucleus, or binding the whole nucleus itself, or maybe this is supposed to be a little speckled pattern. So it turns out that those different patterns are because antibodies are binding to different things in the nucleus, such as DNA, which is very specific for lupus, or this other protein called Smith, another antibody that's very specific for lupus. Also binds to things that aren't necessarily so specific, but are seen in lupus and other autoimmune diseases. So it's an important test, but it has a specific role. And I really try to teach trainees and general pediatricians that it's not the test to run to if you think somebody has lupus. There are lots of other things that I would do first. Okay, next I'm going to talk about the clinical features that are common in pediatric lupus. And this table is compiled from multiple studies that were performed over the years, people doing collecting data on cohorts of lupus patients, and it was compiled in a review in 2018. So you can see there's wide ranges of frequencies of these features because people use different criteria, and there's differences in institutions, et cetera. So they're not the tightest interval here, but you can see very commonly we see constitutional symptoms like fever, we see skin rashes, joint symptoms, kidney disease. Less commonly, but still, happening, some GI involvement, effects on the brain. It can even affect your eyes, other organs. But these are the most common and the frequencies of these symptoms at the time pediatric patients are diagnosed as lupus. So the constitutional symptoms, in addition to fever, we often see fatigue, weight loss, swollen lymph nodes. And as you can imagine, this doesn't sound like lupus necessarily, whereas, it could be an infection, it could be a malignancy. And so it's really important to do a full physical exam, get specific labs looking for other, signs of infection, signs of cancer, signs of lupus, because it's just not very specific. Skin findings, there are lots of skin findings, some that are very specific for lupus and some that are just associated with lupus and some that could be seen in other diseases. The classic that many of you probably know about, the malar rash. It looks like a butterfly here. Classically, it actually spares this area right at the fold of the nose, the nasolabial fold. This is a textbook picture. Not every patient looks like that. We can see really severe photosensitivity, just going out in the sun and getting a really severe rash, not sunburn. Hair loss is also very common. Fortunately, these types of rashes are generally non-scarring, as opposed to some other forms of lupus rash, such as the discoid rash, which can scar. Very common, we see ulcerations on the hard palate up here in the mouth. You can have rashes, mouth sores in other parts of the mouth, on the gums, the cheeks, the tongue, but this is the classic finding. And then nasal ulcerations, I don't know if you can appreciate, but this is actually like a little hole that's eroded into this lupus patient's nasal septum. Again, not necessarily specific for lupus, but if you put it all together with other symptoms, it would be very suspicious. We also can see vasculitis of the skin, so inflammation of blood vessels in the skin, and it can present very commonly on the fingers, the tips of the toes, but sometimes even other parts of the body. This is a pediatric patient with big ulcerations of the skin on his back and shoulder. Musculoskeletal disease, so arthritis and muscle inflammation, very common, the most common being arthritis. And this arthritis can be quite painful and debilitating, but other patients will be asymptomatic. And this is a picture, you can appreciate here these big swollen fingers. This is a pediatric patient. Now, usually this type of arthritis isn't erosive, meaning it doesn't chew away at the bone in the joint, which you can often see in patients who have rheumatoid arthritis. So that's good. It generally doesn't do that, but it can be quite deforming and cause deformities due to the inflammation. So definitely something you don't want to miss and you want to treat. It usually does present pretty early in disease when patients do have it. Again, you can see muscle pain and muscle inflammation, but that's less common in lupus than the arthritis. So kidney disease. This is the #1 cause of both disability, morbidity, and death in our pediatric population. And the most common kind of kidney disease is what's called glomerulonephritis, and that is basically the glomeruli are little filtering units in the kidney, and they are responsible for filtering the blood and taking the good things, keeping the good things in the blood in the body and getting rid of the toxins and putting that in your pee, and then you pee it out. And when there's inflammation in those little filtering units, it's not good. And you can see, patients will even see blood in their urine sometimes. You can have protein in the urine, and urine might look kind of foamy or, maybe dark. Patients can have high blood pressure. Their kidney function can be decreased. They can have edema, swelling from just the abnormal, the loss of the kidney function. And some patients will, even present already with very severe disease and can develop end-stage disease, meaning they would need dialysis and a transplant. It used to be much more common. Up to 50% of pediatric lupus patients would end up going to, end-stage disease, and now it's less than 10% of patients. These patients also most commonly present in the first year of diagnosis, but you can see people who have had fairly mild lupus subsequently develop kidney involvement. And just for some pictures to sort of get a sense, not that I expect you to know the histology of the kidney, but this is a slice through a glomerulus. So this is a normal glomerulus, and you can see all this white is open spaces. That's where the blood would be flowing through, and the cells that are here are just the cells of the capillaries. And so this is a nice, healthy glomerulus. Lupus causes inflammation, and that inflammation is all these blue cells that are, a lot of them are now inflammatory cells. There's things getting deposited. This purplish stuff is all deposited and causing just the kidneys can't filter and do their job. And we know that lupus, autoantibodies play a role in the disease in lupus, and this is actually a stain of a glomerulus that shows that there are autoantibodies binding to the glomerulus and causing this, contributing to this disease. So quite significant. And of course, this requires a biopsy to see. And so if we have suspicion for significant disease, we do check a biopsy. Hematologic findings are really common, although I would say if we talk about mild hematologic manifestations, that's almost every lupus patient I see has some amount of slightly low white blood cell count or, especially low lymphocytes, very common in lupus patients. But anemia, especially an anemia that's due to autoimmune hemolysis or breakdown of the blood cells because of antibodies against your red blood cells, is a specific criteria for lupus and, definitely seen in a proportion of our patients. And this just shows you, this is what a normal smear of blood would look like on the microscope slide, and all the cells look pretty uniform. They have this normal, kind of like a donut appearance, right, with that little central thing. And then when you have the red blood cells being broken down, they're different shapes, they're different colors. This is actually an immature red blood cell that normally would be in the bone marrow. So it's just an abnormal look to the cells. You can also see low platelets, which, platelets are really important for our clotting our blood and not bleeding. And it can be mild, but it sometimes can be more severe. And this is just a picture of a rash that sometimes you'll see if your platelets are low because you get tiny little, almost like little bruises. They're called petechiae. So cardiac and pulmonary involvement, also mild forms, very common in our pediatric lupus patients, but some patients do have more severe disease. And this is just showing you a picture of a patient whose heart looks enlarged. This is the heart. These are the lungs. The black is the lungs. And you can see this would be like the normal shape. But here, this heart looks like it's kind of blown up a little bit, and it's from fluid around the heart. And in this image, the lungs just look like they're all hazy because the air isn't, there's, you don't see just the air, you see a lot of, it's from inflammation from lung disease. And so that is another finding that we see fairly commonly in our pediatric lupus patients. Now, neuropsychiatric, or what we call CNS lupus, is not as common as some of the other manifestations, but it is the second most common cause of morbidity and mortality in our patients. So it's a significant problem, and it's also very difficult to diagnose and sometimes very difficult to treat. And the reason that can be difficult to diagnose is because some of the symptoms are difficult to distinguish from just normal, side effects from medication or depression or fear, of a young child who's been diagnosed with a disease, with a new chronic illness. And sometimes the imaging studies that we do don't necessarily help us. You could have completely normal imaging studies. These happen to show, this looks obviously abnormal. This is the brain, and this does not look like the rest of the brain. In this image, there are actually tiny little dots here. These are little hemorrhages. So you might find something, but you could have completely normal imaging and have a patient be severely affected from neuropsychiatric lupus. So, as I mentioned earlier, these features, while we see them in pediatric lupus, they can also all be seen in adult lupus. So why do we care? Why are we talking specifically about pediatric lupus? And I just found this little image on the internet that I thought was cute because our kids are not little adults. There are significant differences just in the severity, the complexity of our patients, where we really do have additional considerations to keep in mind. And I'm going to show you just one figure from a paper that is somewhat old now. It's 2008, but it was a sentinel paper looking and comparing adult lupus patients with a matched set, so patients that had similar onset, years of diagnosis, similar gender, similar race, but were adolescent when they were diagnosed, and comparing the adolescent patients from the adult patients in a large multi-center U.S. Cohort of lupus patients. And so the adults were 19 to 50 years old, whereas pediatric or adolescent patients were less than or equal to 18 years. What they found is that there was a significantly higher percentage of juvenile or adolescent patients who were African American, compared to 51% compared to 27% of the adults. The adolescent patients were much more likely to have kidney and neurologic involvement, and I'll show you that on the next slide. They were also more likely to accrue kidney damage. And that's interesting because in general, a lot of studies demonstrate that adult patients tend to have more damage than pediatric, but specifically the kidney damage was more prominent in the pediatric patient. And I think that reflects the fact that we do see more severe disease and higher percentages of kidney disease in the adolescent and pediatric population. The most striking thing of this cohort, though, was that at 5 years from diagnosis, the adolescent patients had twice as high mortality rate compared to the adult patients, which was quite shocking. And so this is just a figure demonstrating that The adolescent patients who had onset in adolescent are in black, and the lighter bar are the adult onset patients. And if you see here, these are other manifestations that are fairly similar, but the kidney disease in the adolescent patients was at about 80% compared to maybe about 45-ish%. And again, the neurologic involvement was more than double in the adolescent population. So definitely our patients, do have more severe organ involvement and more active disease that persists. So what about long-term? We definitely have made significant improvements, and I'm always hopeful that, while I know our patients can be quite sick, I'm very hopeful that any lupus patient we see, we can get them to a point where they can live a normal, healthy life. But there still are a lot of consequences long-term for our pediatric patients. And in some ways, because they start so young, they have many more years to accrue damage and, experience flares. And so if you think about a patient who's diagnosed at age 10, by the time they're 30 or 40, they've had that disease for many more years than someone, by the time if they're diagnosed when they're 30, they're already a little bit older. So they don't have as long to go. So we really need to take good care of these patients. So what are the contributors to morbidity in our patients? First, of course, is the fact that they have life-threatening organ system involvement, and that ongoing activity of disease leads to potential damage and chronic changes. So if you have kidney failure and you need to be on dialysis and you need to get a transplant, it's likely that a pediatric patient will require more than one transplant because the lifespan of a transplanted kidney is only about 10 years for a lupus patient. So if you get a transplant at 10 or 15 or 20 years of age, you're going to require multiple transplants or going back on dialysis. Similarly, the risk for heart disease, we learned as our outcomes for lupus improved and patients were living longer, it became apparent that young women were having cardiovascular disease, much younger than patients without lupus. And we now know that in our adolescent population, already a significant portion of them, about 2/3, have abnormal lipid panels. And when evaluated, even children will have subclinical abnormalities in their heart perfusion. So the blood flow to their heart can be detected as abnormal in about 16% of children with lupus. So the risk for going on and having stroke or heart attack or other cardiovascular bad outcomes is very significant. And of course, we know that lupus patients can have cognitive defects, difficulty with memory, other cognitive function, and also issues with depression and other CNS disease. In addition to the morbidity from the disease itself comes the morbidity associated with our treatments. And unfortunately, you likely know that there, especially with steroids, there are a lot of side effects. And, in our adolescent population, cosmetic effects really impact our patients. This is a photo of a before and after being on high dose, before and during high dose steroids. And you can see the significant weight gain, Cushingoid face in this patient, acne, some patients develop increased hair, stretch marks, and those have really, really severe impact on our patients. There's also other issues related to steroids, such as growth delay or delay in puberty, impact on the bones where you get avascular necrosis or osteoporosis. This is just a little graph to remind you that we build our bone, it's kind of like a bank, and we build it up in our teen years. And then once we get here to about age 20, these are years, and we don't build a lot more. So if you're having active lupus and on high-dose steroids and it's affecting your bone density, you may never get your bone bank to where it needs to be for the rest of your life, and you're at risk for osteoporosis and the consequences of that. And of course, you can see effects, long-term effects of steroids on the eye, such as cataracts or glaucoma. Some of our other medicines also have their own risks, and fortunately, we have newer medicines and we don't have to use cyclophosphamide as much as we used to, but it was a mainstay for our lupus nephritis and our patients with lupus, neuropsychiatric lupus. It has significant concerns for fertility as well as risk for malignancy. All of our medicines, for the most part, do some amount of suppressing the immune system. That's how we calm down that abnormal immune response, while we're also preventing the normal immune response. And so we have increased risk for various infections, and especially things like chickenpox or shingles, herpes viruses, other opportunistic infections that most of us would handle can be a problem for our patients. And there was this lovely study just published a few years ago looking at a very large number of pediatric lupus patients. So over 1,000 patients from 3 groups in Europe and Cincinnati. And they looked at lupus damage in lupus. There's this thing called the SLIC damage index, or SDI. And it's basically just like we have the classification criteria, we have this criteria to calculate damage, and you get a score, 0 to 14. And what this study showed is that when patients were last followed up, which ranged anywhere from average 3.8 years, but some patients were followed much longer, that already about 44% of patients had some amount of damage just within the first few years of disease. And that was most commonly problems with too much protein in the urine, which can be damaging to the kidneys, hair loss with scarring, so not being able to regrow the hair, and chronic cognitive impairment. And this graph here is showing the 4 most commonly damaged organ systems. So we have yellow is neurologic, and this is at start of diagnosis, and this here is the percentage of patients with damage. So you actually start this score at 6 months, so I'm not quite sure why it already says at diagnosis there were patients, but over time, a significant percentage of patients had some type of neurologic damage. Similarly, this green here is the kidney, and the blue is the skin, and then the red is musculoskeletal, so either fractures or osteoporosis, et cetera. So definitely a concern that there's significant damage already occurring within less than 5 years. So what about mortality? This is a very busy slide, but I think it shows very nicely that we have made significant strides. So I'll just point out that this was from a paper that was looking specifically at lupus nephritis, but does report overall lupus patient survival. And these are studies that were performed at different time frames on pediatric lupus patients in various places in the world. So in the 1940s and 50s and 60s, the survival rate for pediatric lupus patients was somewhere between, in this study, 28% 5-year survival. This study was 56% 5-year survival. If you had nephritis, so kidney disease, you had a 23% 10-year survival. That's, you know, fortunately, we've made significant strides. And as you see, going into later years, here's more like 1980s, 1985 to 2007, we're seeing this number isn't very good. We'll go with this one, 1990s. So these are different studies that have different, you know, outcomes, of course. But you know, we're now at a point where, in general, the 5-year survival is considered more than 95%, and the 10-year survival generally is reported as a 86 to 90%. I mean, there's one study here that showed 100% in 9 years, which seems quite impressive. But, you know, we have a ways to go with that. And this is just a study, doesn't really represent our, the US, because it's specifically from Thailand, but I thought it does a nice job in sort of graphically representing the improvements over time. So if we look at, this is the probability of survival. So up here, everybody survived. Down here, everybody did not survive. And this is time. So from 5 years, 10 years, up to 25 years. And what you can see is they have data from some older studies, 1985 to 96, was a group of patients that were followed. And that's this dark line. And so over time, you know, by 25 years, there's, you know, 30% or so people, 40%. The next cohort, which is just a little bit newer, 97 to 2006, seems to follow that similar trend, although maybe it's getting a little better out here. But the more recent cohort of pediatric patients, taken just from, you know, the last decade or so, you can already see that their trajectory is much better. Now, we don't have the data out here yet because it hasn't been 25 years, but we'd like to see this line flatten out. So I think that's encouraging, and that's what's being seen in other cohorts that are being evaluated. And this just sort of looks at the data another way, and it was looking at number of patients who are admitted to the hospital and those that died when they were in the hospital. And you, in the earlier cohorts, that mortality or percentage of mortality was, you know, pretty high, like 50%. And in the newer cohorts, it's much lower. So here you have 173 people admitted, 18 deaths versus 31 admitted, 16 deaths. So significant improvements, you know, in various cohorts that have been described. Okay. Next, I'd like to just move on to other special considerations we have regarding our pediatric patients. First, we'll start off with education. So if you think about it, school is really our pediatric patients' job, right? They need to be able to do school. That it's really important for them to do, and we know that having lupus can affect the brain and cause cognitive deficits. And it can be very frustrating, and we'll often have patients say, you know, I used to be an A student and now I'm failing my tests, I can't concentrate, I can't remember things. And there is actually neurocognitive testing that's available. Sometimes it can be challenging to get insurance to cover it, but I think it's really important to consider, especially if you're having any reports of difficulty with school, changes in behavior, changes in even mood, and interactions with friends and family. You know, you can really benefit from getting that testing. And of course, it's important to be aware that the schools have resources, and at least in the public education, they're required to provide accommodations such as a 504 plan or an individualized education plan, making those accommodations for the the patients, such as, being able to have an extra set of books so they don't have to carry them if they have arthritis, or putting sunscreen on, or, not having PE at noon, when the sun is most intense. And we always tell our patients as they're preparing for college that they should register with the Office of Student Disabilities, so that if something does go wrong, they have that already set. Next, other psychosocial issues with our patients is that even the most well-adjusted adolescent or young adult could still have problems. So it's, this is just issues with the psychosocial stage of development. There's peer pressure, there's a lot of emphasis on appearance and body images. Kids don't want to be different. They have a hard time really comprehending the future. They're living for today. Some may feel, they're invincible, or even if they know there's a risk, they just take it. So it's important to recognize, obviously, if there's any changes in mood, important to encourage counseling. If there are peer support groups, certainly from the Lupus Foundation, we have some great mentoring programs. So things to keep in mind for your adolescent patients or children. So why is adolescence such a problem? This is a time when kids are learning to separate from their family and become independent. And they have a lot of peer interactions that are in many ways more important to them. And they do seek new things and take risks. And they really need to be able to have better cognitive development that doesn't take place until, our brain is not myelinating as fast as the kids are wanting to be independent. So that can be a challenge. And so, when there are things that are really compelling to them, they may not make the right decisions. And this is an example of that brain. So myelination, which is important for making our white matter and where a lot of our higher cognitive function takes place, isn't complete until we get into, our early 20s. You don't have the full development of the brain. And this is actual imaging showing that, as the brain matures, you have a change from more gray matter to more white matter. And without that, if we have kids here, they're not making the best decisions because they don't have all of that brain development that adults have. And this is kind of shown here, so it's maybe a little challenging to see, but as you get older, you have less impulsivity, and you have more higher thinking. And these are those two lines, and there's this period where they don't match. And so you have this period of adolescence where there's risk because of the discrepancy between rational thinking and impulsivity. Another thing to consider is non-compliance or non-adherence to medications. It's a huge problem in our patients. I've had patients lose a kidney because they swore up and down they were taking their medicines, and they weren't, and they went into rejection from their transplant. These data are from not necessarily lupus patients, but other transplant patients, where it was shown that in adolescent patients, non-adherence was a significant cause of rejection and loss of organs for liver transplant patients, heart transplant patients, and kidney transplant. And it's really a really risky time when they're transitioning to that adult, into an adult provider. These are just some ways to think about how to approach improving adherence, having a conversation with them, being honest, non-threatening, trying to understand the barriers and coming up with ways to approach them being able to be more adherent. But it's hard. And I can talk till I'm blue in the face with my patients, and I always tell them I want them to be honest with me, because if they tell me they're taking their medicines and they look like they're flaring, I might add a new medicine or increase their medicine. So I really want to know, and I want to have them trust me and have that relationship with me to be able to honestly tell me, yeah, you know, I haven't been taking it. I take my medicine. I feel different. I feel anxious when I take my medicine. I don't want to take my medicine. And then I can help come up with ways to deal with that and, you know, use our resources in our clinic to help our patients. This is the second to the last slide. So transition to adult care is a huge area that still requires a lot of work. It is the most dangerous time for our lupus patients, especially if they are not stable and really doing well. But even those that are doing well, there's such a difference in the adult care model compared to our pediatric model. So it can be very dangerous. And it's important to assess each patient's readiness, because some patients will be more delayed. You know, you see delayed maturation. Some patients seem really mature, others are less mature. If there's a flare, they may regress. There are different stages that we sort of think about, starting even as young as 12 or 14, having them learn their medications, know what they're for. But you're not going to be they wouldn't be responsible, shouldn't be responsible all by themselves to take those medicines, but we want them knowing about their disease and learning. And then as they get a little older, you know, maybe having them have some of the responsibility, helping set up a pill box, or you know, making sure they kind of have that primary responsibility, but you're still monitoring them. And, you know, as you move closer, learning about insurance, learning how to navigate the healthcare system, all of those things that parents do for their children, they need to learn before they go into that adult world, or it's not going to go well. So it's very important. And I really try hard to make eye contact with my patient. If the mom answers the question, which they often do, I look back to the patient and, you know, ask them and say, you know, I want to hear it from you, because that's what they are going to need to succeed in the adult world. So in summary, even though this is not a summary of everything, but more the concerns that we have in adolescence and in young adulthood, there's cognitive immaturity that leads to a lot of issues with impulsivity, risky behavior, being more emotional, and it really leads to this perfect storm in a bad way. And patients who have lupus, if they have really severe disease and they're not developed, you know, emotionally developed, cognitively developed, that's a bad scenario, and they are really vulnerable for outcomes. And so we really need to support our kids, and you know, we're fortunate here at Stanford and most pediatric rheumatology centers, we have social workers, and we have you know, staff that can help us try to support the patients and get them through this crazy time into the adult world successfully. Okay, that is the end of my presentation. So I am going to stop sharing, and I'm happy to take any questions. I hope that was helpful.
That was great. Thank you, Dr. Balboni. We had a few questions come in. Let me ask the first one is, what is the typical age that lupus develops in children?
So most commonly we see sort of around what's reported as the median age is around 11 or 12. I would say most typical for us is, you know, around there, maybe a little bit older, early teens. But we do sometimes see very early disease, and that can often be more severe.
Okay. Here's another one. Can vaccinations trigger lupus?
Good question. And I do want to say I did not have time to put anything in about treatment. There's lots of things we do recommend, and vaccinations are actually some of the things we do recommend. So in theory, anything that stimulates your immune system could potentially accidentally or inadvertently stimulate that bad immune response or that self-immune response that you've had. There have definitely been concerns regarding certain vaccines that, you know, when they first come out, we kind of want to see if there's any issues. In general, it is not the case. And we actually encourage our patients to get their annual flu shot. We recommend actually the COVID vaccine if they can. Now, it's really important to get pneumococcal for the pneumonia vaccine because lupus patients are actually more susceptible to some lupus patients to being at risk for that. So there's actually guidelines that suggest you should do those vaccines, do additional vaccines in lupus patients, but not live virus vaccines if they are on any medicine that suppresses the immune system.
Okay. And their doctor would tell them that up front, right?
Yeah.
And let them know.
Yeah.
That's great. Is lupus similar to AIDS?
Is lupus similar to AIDS?
Yes.
No. Actually, it reminds me of my childhood. I was actually diagnosed with lupus when I was a teen, and my roommate in college thought that it was AIDS because it's an autoimmune disease. And so it has those three letters. And in fact, it's an autoimmune disease, whereas AIDS is acquired immunodeficiency. And so that's an infection, and that infection causes your immune system not to work well. And so you can't fight infections. In lupus, it's kind of almost the opposite. Your immune system is overactive and just reacting against yourself. And so we then suppress the immune response as part of the treatment, but completely different, not related. There's nothing you could do to make the lupus, it's nothing anybody's done to cause the lupus. It's not infectious. It's not contagious.
Great. Here's one. If a patient is diagnosed in their late teens, early 20s, and diagnosis can usually take several years, are those individuals considered to have pediatric lupus?
Another good question. We struggle with this sometimes when patients, do come to us later, but seem to have had symptoms for many years. I think it really has to be when you meet the full criteria. So even if you've started having symptoms, say when you're 17 or 16, but really don't fully develop all of the symptoms to be diagnosed with lupus until after, then it would be considered adults. And again, the two are not really two distinct diseases. It's just that younger patients tend to have more severe disease.
Okay. Here's another question. Is lupus genetic?
So yeah, we do know it's not. Okay. There are definitely genetic factors. For the most part, most lupus is not just one gene causing lupus. It's more what we call polygenic. So many genes that might not necessarily even be like a mutation, but more a variant of normal that affects how the immune system works, come together and cause that increased risk, that genetic predisposition. However, you'll probably learn tomorrow, I think Dr. Newell will talk about it, there are what we call monogenic lupus syndromes, and there are some specific genetic mutations that are associated with lupus and often early onset lupus, but that's not the majority of lupus patients. But when we have a young patient, someone who's 3, 4, 5 years old, would definitely, or someone who has really severe disease, we definitely think about those individual monogenic diseases that have been identified.
Thank you. Will my child need to be on medication their whole life?
Yeah, that's a tough one. It depends. I've been taking care of lupus patients since about 2002, and so I've seen a lot of my patients go on into the adult world. Some of them successfully off medications before they leave me, some of them not. So every patient is different. What we do know is that patients who respond very well and don't flare in the first few years of disease are more likely to fare better with less flares or needing more medication later, but it's always possible to have a flare. And some patients, they do unfortunately need to stay on medication. That may only be some, sort of mild maintenance medicines, not necessarily the full-blown, immunosuppression that we're using to get the disease under control initially.
Can physical bodily trauma trigger the onset of SLE?
Yeah, I think it's certainly possible. I've not seen that, but we know that there are something triggers that immune system to go a little bit awry and start attacking yourself. And so we've identified lots of things that we know can do that. And, definitely infections, certain infections can trigger an infection that someone else will get and not have not develop lupus, but in someone who's susceptible. And an example of that is mononucleosis or the Epstein-Barr virus, definitely associated with lupus diagnosis. But, I could imagine if some severe trauma happened, could it somehow jolt your immune system? I can't say it wouldn't, but I've not seen that.
Okay. Does diet or specific foods cause flare-ups in children?
Fortunately, I think you're having a session about nutrition next. I would say that in general, my perspective, there's lots of different perspectives, but for my pediatric patients, I generally want them to be eating a healthy diet and not restricting significantly, like if you try to cut everything out. But there are definitely some patients who do feel that sort of processed sugars and a lot of processed foods, gluten, can bother them. So I definitely let people, sort of explore, and if they want to try to see if certain foods make them feel better, I'm okay with that. It won't make the lupus go away, but some people definitely do seem to feel better removing certain foods from their diet.
Okay. So if someone has lupus and they have grandchildren, should those grandchildren be tested even if they have no symptoms?
Definitely not. We do know that there is a higher risk of developing lupus in family and for children who have family members with lupus, but it's not a guarantee. It's just an increased risk compared to the general population. So what I generally tell people is that, we don't want to go do testing. First of all, because you could find a positive ANA, and it's just because there's a positive ANA and it doesn't mean anything. But it's being more aware of what the symptoms are, and if there are any questions or concerns, seeking the care from the pediatrician to evaluate, and if indicated, send some labs. But I wouldn't recommend it if there aren't symptoms.
Okay. Kind of leading into that as well, this person asks, is it helpful for physicians to hear the stories of their patients' lives, i.e. anything the patients or families think may have a connection to lupus for the years preceding a diagnosis?
Yeah, I do think that that's helpful. I mean, we generally try to ask about symptoms that things that might have preceded the symptoms, but we certainly don't, necessarily go back, beyond, for years. So if there are things that are thought to be important, we do like to know the whole story. And, especially if there were unusual exposures or things like that, we may not be able to tie it together, but it does help sometimes to have the story.
Okay. Is there a higher rate of lupus in children who have had multiple operations during childhood?
Not that I've not heard of that, no.
Okay. Is Plaquenil dangerous to take?
my simple answer is no. We actually kind of jokingly call it vitamin P because it is essentially something all of our lupus patients take, unless they do have a true reason not to, like an allergy or severe side effects. But the side effects are actually very uncommon. The biggest issue, and one that we do monitor for, is that over time the medication can get deposited in the eye and cause some changes in some of your visual fields, like being able to see in your periphery, and can affect your vision. And that is obviously very dangerous if that were to happen. But we, first of all, it generally doesn't even happen for the first 5 years of taking the drug. So in adults, they don't even start looking until 5 years on the medication. And there are some really specific guidelines on how much to take to decrease that risk. And then we have our patients see the eye doctor and get specific testing that looks in detail at the eye. So if you do that and you follow through with that, you should find something way before there was any actual symptoms. Obviously, anybody could have an allergic reaction or have some other rare side effect, but in general, I would say it's the safest medicine we use to treat lupus patients with, and it works really well. There's lots of data out there that show it helps decrease risk of flare. It helps actually delay progression to lupus in people who have been on it and haven't yet been diagnosed with lupus. So it really does it really is beneficial for our lupus patients.
Great, thank you. Does an infection such as a localized gangrene, can that trigger lupus?
I suppose, again, we do think that certain infections can trigger, sort of be the triggering event. I generally think of those as more systemic infections or viruses, things that get into your bloodstream and affect your immune system more than just a localized infection. So not really sure. I think you certainly could see gangrene in someone with lupus as a complication of the lupus, but I've never seen it cause lupus.
Okay. Do rheumatologists work to better inform pediatricians as to the signs and symptoms of pediatric lupus?
We try very hard. That's actually one of our goals. Here at Stanford, we do a lot of continuing medical education for general pediatrics. We hold them in the East Bay, in the South Bay, in the North Bay, and they often ask the rheumatologist to be one of the subspecialists talking, and I talk a lot about what the signs and symptoms are, what things you need to worry about besides lupus, and when to do the testing, what testing to do. I say don't do an ANA, but if you're worried about lupus, do some basic things that would show you if there's inflammation. Check some inflammatory markers, check your blood count. So we do try. I do think that pediatricians have a tough job. They see a lot of patients, and actually this year with COVID, it's been really hard. A lot of patients are coming in with a lot more complaints of pain and fatigue, and it's always in the back of a pediatrician's mind, could this be something that I'm missing, and you don't want to miss it. So I can't fault them, but I do try to educate them on how to appropriately work up lupus.
Great, thank you. We're going to be closing out our Q&A shortly, so if anybody has any questions, please feel free to keep asking them. One other question is, how would I find out about clinical trials for lupus, and are there ones available for pediatric lupus?
Yeah, so the best way to find out about clinical trials for anything is there's a website called clinicaltrials.gov, and that lists, you could basically search for any disease, or if you know a drug you're interested, like if there was a drug you wanted to know was in a trial, you can search and find trials that are open. At the moment, I am not aware of any pediatric trials, but that doesn't mean they're not happening. Generally, the way things work, of course, is that the drugs get tested first in adults. Fortunately, there is now a rule that if you are developing a drug that can be used for a disease that is affecting pediatric patients, you do need to, evaluate it, but they first try in adults because we want to be as safe as we can with kids. In the old days, they wouldn't study children at all. And then, a lot of the medicines that we use because of that are off-label or aren't approved in children. And many of the drugs actually have never been approved for lupus. But there have recently been some promising drugs, but I'm not sure if there are any open trials at the moment.
Great, thank you. Well, it looks like our questions have finished up. So thank you, Dr. Balboni, for your time. That was so interesting. It was really informative. We really appreciated it. To the participants in the audience, don't forget to complete your survey before you leave. This is going to end the end of session 1 now, and we're going to take a brief break. We hope everybody joins us again at 1. As Dr. Balboni referenced, we have a health nutritionist joining us in the afternoon session. And then tomorrow we have Dr. Nywald joining us talking about the genetics of lupus. So all of these are going to be very interesting. But again, thank you so much for your time, Dr. Balboni. We really appreciate it. Participants, the link to join this morning is the same for this afternoon session, and all day tomorrow it's the same session, same link. So thank you again, and we will see you guys soon. Bye-bye.
All right, take care. Bye.